And we're recording. And I am joined by the amazing Dr. Meric from IVF Turkey. Dr. Meric, thank you so much for your time today.
Thank you. It's a great pleasure to be with you.
Oh, thank you. We wanted to basically steal you away for half an hour today to just ask for your help in terms of getting our heads around the basics when it comes to understanding the different types of fertility treatments that's out there,
Right.
and what sorts of treatment suits what kind of person. Can I start from the very beginning though? So if you are, let's say you're 35 or under, and you have been trying to conceive for a year and it hasn't happened, what should you do?
Okay. First of all, as you mentioned, the age matters. Let's start by describing infertility. If you are under 35, 1 year of unprotected intercourse without any success, without having a baby, it can be described as infertility. But if you are over 35, it's considered to be 6 months rather than a year. So let's start with relatively younger ladies, okay? If you are 30, 31, under 35, and if you do not get pregnant after a year, then please apply to one of the gynecology services to get some information on the infertility. So we usually start by examining the lady. Gynecologic exam reveals very important points to us, such as the shape of the uterus, the number of antral follicles in the ovary, and the cervix and the vagina can be examined by gynecologists. And if there is any abnormality, it can be detected at first hand. So the first step is to have a gynecologic exam. The second one is to get a sperm analysis. It's simple, easy, and a cheap procedure, giving very information on the sperm and on the male factor. Then the other part would be to check the uterine cavity and the tubes. There is a test, so-called hysterosalpingogram, that shows the tubal patency and the shape of the uterine cavity. So this should be done to rule out the tubal factor. That means if the tubes are blocked by any reason, it can be diagnosed by having hysterosalpingogram. And the fourth step would be getting hormonal analysis of women that might be FSH, LH levels, prolactin assessment, prolactin hormone assessment, as well as thyroid function tests, TSH and T3, T4 assessments. By doing so, we end up having very detailed information on the reason of infertility. And almost 60% of couples can be diagnosed having one of the problems, such as tubal blockage, male factor, or some ovulatory dysfunction after having all these methods. But again, almost 1/3 of couples do not express any abnormality upon having these 3 tests done. They are so-called classified as unexplained infertility. Then after having all these tests, we just handle or plan the next step, the next treatment, or discuss the treatment options with couples to proceed.
Mm-hmm. And so can you just, because there's so many different variants, you know, you've got IUI and IVF and ICSI and mild, could you just briefly describe what these different procedures involve? So for example, IUI to start with.
Okay, so let's take an example. She is young at the age of 30 and she needs to have patent tubes, bilateral tubes should be patent, or at least one tube should be patent to undergo an IUI cycle. Otherwise, if there's any problem with the tubes, IUI will not work, since we need a healthy tube to meet the sperm, meeting of the sperm and oocyte inside. Therefore, in order to go through IUI, the lady should have at least one patent tubes. Also, the sperm analysis should reveal a normal sperm count, at least 1 million sperm per milliliter should be found in the sperm analysis to undergo an IUI cycle. Severe male factor cases should not go through IUI, since after washing and after inseminating the insemination of the sperm inside the cavity, we end up having very few number of sperm inside the tube that do not work, may not be able to fertilize the egg inside the tube. Therefore, there are two rules. There are two rules to go through IUI. First one, normal patent tube, at least one patent tube, and normal sperm analysis. The pregnancy rate through IUI is about 15%, not very high. So if you have very low sperm count or disturbed tubes, the pregnancy rate would drop to 4%, 5%, and then we come to the decision whether or not it's worth going through an IUI cycle. So 1%, 2% is very low percentages, very low likelihood of pregnancy, and it may not worth trying IUI. You better go through IVF rather than trying IUI. So the first two rules, normal sperm analysis and patent tube, would be fulfilled before to undergo an IUI cycle.
I always feel quite frustrated when I hear about IUI, because I had 2 rounds of IUI that both failed, but my husband had lazy sperm, shall we call it. So, and so eventually I then had failed IVF, and it was only when I had ICSI that it finally worked. I wish I could go back and skip the whole IUI bit.
In fact, there is no mistake to go through IUI in the first cycles, because we usually go step by step. Since you were diagnosed having normal tubes and within normal sperm analysis, lazy sperm or a little low count can be accepted in the IUI cycle. We usually start with IUI in that kind of couple, so there is no mistake about it. Because after 2 IUI cycles, almost 20–25% of couples end up having a baby with a cheap, with a very economically reasonable method. And if it doesn't work with IUI, then you go through IVF cycles. In the past, we opt to try at least 4 IUI cycles prior to advancing to IVF cycle 4. But now, after the IVF became more common worldwide, and couples try to get pregnant in a very short time, then we do 2 IUI attempts maximum these days, rather than 4. So it's changed. Maybe in the future it's going to be one or maybe none. But we need to, you know, follow the scientific guidelines.
Yeah.
IUI is much cheaper than IVF, so therefore we usually start with IUI if the couples are met the criteria.
I think the thing is that when you're trying to conceive, time just is so precious and you want to fast track as quick as you can. And so
You're
we
right.
get a lot of messages from people saying, well, why do I have to go through that? Why can't I just go straight to ICSI? Why can't they just get the sperm and get the egg and put it in? And surely that's going to have a quicker and faster and more successful outcome.
Yeah, you are correct. But therefore, as we meet the couple, we are supposed to give all these details and pregnancy rates in all these attempts, through all these attempts, IUI, IVF, and ICSI. There are always pros and cons of each attempt. As I told you before, IUI costs almost 1/3 of IVF. So if you recommend IVF to all couples, some of them may end up saying, okay, I like to start with a cheaper method. So you can be criticized on your decision. Therefore, we usually start with IVF if the couples meet the criteria.
Yes. And if you were doing, so for IUI, for example, so how long does that take from the minute someone comes to see you to then actually going through the process of IUI?
It takes approximately 10 to 12 days to stimulate the ovaries. We use cheaper medications to stimulate ovaries and aim at recruiting 1 or 2 good follicles, 1 or 2 good eggs out of this ovulation induction procedure. Whereas in IVF cycles, we aim to get 5-6 eggs. The optimum number is about 8-9 in IVF, but in the IUI cycle, 1 or 2 follicles are enough to go ahead. So therefore, we use much less medication to stimulate the ovaries for IUI. It also decreases the cost of procedure. Economy or cost matters. So we also tend to use some tablets, oral tablets, to stimulate ovaries, such as clomiphene or letrozole. But in IVF, we generally do not use tablets. We only use injections to give a more potent medication. So from the beginning, it takes 10 to 12 days to stimulate the ovaries, and then we give the last trigger shot to stimulate ovulation. After the trigger shot, we do IUI 36 hours after the trigger shot. IUI takes only 5 minutes at the office to complete. So you don't need to be put on sleep. This is another advantage of IUI: short, cheap, and you don't need to be put on sleep. Whereas in IVF cycles, we use some mild sedation to collect eggs. So it's simple, but from the beginning to the last, it takes approximately 12 to 14 days to complete.
And so moving on then to IVF, who would you say should not have IUI and should go straight to IVF?
First of all, the sperm analysis gives a very informative, very precious idea on the patient selection. If sperm count is low, motility or morphology should be evaluated, and it's so-called severe male factor. These couples should never go through IUI cycles, since the pregnancy rate is very low through IUI. This is the first rule. The other one, if the woman has a tubal factor, any problem in the tubal patency, they shouldn't go IUI because, you know, so as to get a good pregnancy rate, women should have normal pattern tubes without any adhesions and no previous surgery. So in case of in the presence of adhesions and tubal problem, they should go through IVF rather than IUI. These are two rules of thumb to postpone or to cancel IUI and go through IVF cycle.
And can you explain the difference between mild IVF and standard IVF?
Okay, the optimum number of we usually try to get as many as 8 to 10 eggs to get a good fertilization and good embryo out of it. So therefore, we stimulate ovaries. And after stimulation, follicles grow and end up being like 8, 9 in numbers. However, there is a problem of using this strong medication. The first one is the risk of ovarian hyperstimulation, and of course the cost of IVF would be increased by using these injections. In recent years, there's a mild stimulation. In mild stimulation, we use tablets and low dose to stimulate ovaries. However, the side effect of mild stimulation is to end up having 2 or 3 follicles rather than 7, 8. Mild stimulation, however, doesn't have the risk of ovarian hyperstimulation. So there are always pros and cons of treatments. So by doing mild stimulation, you use much less medication, the dose of medication, and they prevent the risk of ovarian hyperstimulation at the expense of not having a good embryo out of the stimulation. If you are over 35, approximately 1 out of 6 to 8 eggs become a good embryo, good blastocyst. So the number of eggs matters in the course of IVF. Mild stimulation is used usually in the Far East countries, but these patients, these couple, are opt to go to the IVF center several times because some first trials might end up having no embryo available to transfer. This is the cons of the shortcoming of mild stimulation. So we need to discuss the couple prior to starting an IVF cycle, mild or the conventional treatment. Mild is okay, but sometimes in the first 1 to 3 attempts, we end up having no embryo to transfer. So the couple should understand the pros and cons of the treatment of IVF. So mild stimulation is not a gold standard. Actually, conventional IVF is a gold standard. But if the couple want to avoid ovarian hyperstimulation, and if they live in the country of IVF, like in Turkey, Turkish couples might, up to this mild stimulation. But otherwise, it's a very we may end up having nothing out of this.
And can you also explain what the difference is between a long protocol and a short protocol? Protocol basically means plan, right? It's your
right. This is
plan. Yeah.
This is the plan of stimulation of ovaries. In the when we started IVF, when IVF started in late 70s, we started stimulating ovaries, follicles. But almost in 20% of cases, follicles ruptured prematurely. So we ended up having nothing to aspirate. Then scientists tried to find some methods to prevent premature rupture of follicles. And GnRH analogs were invented to prevent LH surge, because LH surge was the culprit, was the factor to cause a premature rupture of the follicles. And almost 20 years ago, GnRH analogs was used to suppress LH surge. But GnRH agonist analogs was started in the luteal phase of the previous cycle, and it was used almost 20 days to prevent LH surge. This compelled couples to come visit IVF clinics before their next cycle to start GnRH analogs, and GnRH analogs was used almost 20 days. It actually prolonged the duration of staying or duration of IVF treatment. Then almost 10 years ago, GnRH antagonist was invented. GnRH antagonist prevents LH surge right away, instantly. GnRH antagonist is started on cycle day 6 or 7, since their effect starts immediately. This made our work much easier, because we called the couples over to the IVF center, started ovulation induction agents on cycle day 2 or 3, and on the 6th or 7th day, we started antagonist, and it prevented LH surge. So it made our work and patients' duration, patients' work much easier. In Turkey, almost 99% of cycles, GnRH antagonist is used. It's easy, and it keeps us very in the program. There are some cases only GnRH agonists are used. In terms of the difference pregnancy rate in the pregnancy rate, there are some studies showing that they both are equally effective. So please talk to your consult your physician which one is suitable to you. But in most cases, GnRH antagonists are more handy, usable or beneficial.
So that's short one.
Short one,
yeah.
Practical to use them. And we can achieve LH suppression with GnRH antagonists, and therefore it's very commonly used in Turkey now.
Yes. And one of the things I remember specifically from my IVF cycle was during stimulation becoming absolutely obsessed with the development of my follicles. And I'd write down in my little diary, you know, every time I'd go and get monitored, I'd write down how big they were getting and how many. So like, what are you working towards? Like, what is the kind of, not so much the best score, so to speak, but what you can get away with? Because I think that's what people just need to know. What's the least I can get to that might mean that it will work? Does that make sense?
So you mean the size of the follicle or the number of follicles?
Both. What do you need as a doctor to make my IVF work? Do you know what I mean? What happens if you're not stimulating properly? What is the kind of, what can we get away with?
Okay, first of all, the number of eggs matters. There are studies trying to observe, trying to find the best case to get the highest pregnancy rate. If you end up having 8 to 10 eggs out of this ovulation induction, it means you will have at least 4 to 5 blastocysts, embryos, good embryos, to transfer, and then your likelihood of getting pregnant is almost 60–70% after 2 transfer, 1 fresh and maybe 2 frozen embryo transfers. So the number of follicles does matter in the progress in the success rate of IVF, which that is 8 to 10. And the size of the follicle, we usually, when we start giving medication, we follow the ovarian response by vaginal sonogram as well as hormonal assessment. But vaginal sonogram is the gold standard. It's very common, found in all gynecology clinics, and simple to measure the follicles. We aim to get them being 17, 18 millimeters in diameter before planning to aspirate. So if during the ovulation induction phase of the cycle, if you have 8 to 10 follicles or 8 to 12 follicles measuring at least 17, 16, you are considered to be lucky or having high success rate through IVF cycle. And the other part is the male, of course. Your husband should have normal spermatids, or at least normal spermatozoa with normal shape and motile should be found in his sperm sample. Then your chances are high. We usually talk about the success rate. Cumulative success rate is the main denominator or the mark to talk about. Not just after one IVF cycle, but after 3 IVF attempts, 1 fresh and 2 frozen attempts. If you meet these criteria, a normal sperm, good number of eggs, good quality eggs, your chance would be 70 to 80% after 3 cycles, which is, a very satisfactory result.
What would happen though if you only produced like 4 follicles? I know you're saying 8 above is what you're aiming for, but what happens if you're lower than that?
We do our best, of course, but if you have 4 follicles, normally, under normal circumstances and naturally, 3 of them will get fertilized, and only 1 or 2 of them will reach blastocyst stage, so day 5 stage. We transfer whatever the couple has, but normally only 50% of eggs reach blastocyst stage, depending on age, of course. This is in a young couple, relatively young couple, in a not relatively young woman at the age of 35, 34. But if you are 40 or 42, then 1 out of 8 eggs will be producing a live birth. So 1 out of 8. Unfortunately, this is the nature. So.
Oh my gosh. And the trigger shot. Now, this is something on my IVF round I completely messed up. Because you're given a specific time to take your trigger shot, aren't you?
Right.
Why is that timing so crucial?
The trigger shot is so-called LH surge. We try to mimic natural cycle. In a natural cycle, LH stimulates oocyte maturation. And after LH surge, 36 hours after LH surge, oocyte becomes mature. We are compelled to aspirate the oocyte just within 34 to 36 hours after LH surge. In other words, after this trigger shot. If we do aspirate oocyte egg earlier than that, we may end up having nothing because maturation couldn't be completed before 34 hours. Or if you try to aspirate the egg after 36 hours or 38 hours, spontaneous rupture might take place and you might end up having nothing, and you might find nothing on the ovaries, since all follicles might rupture. So it's very important to get this injection on time and go to the clinic precisely just before egg collection timing. It should be between 34 to 36 hours after the trigger shot, not earlier, not later. Even though we described our patients when to take this injection, unfortunately, they make many mistakes to get this injection, and all efforts would be in vain for nothing. After all this money and efforts should end up being nothing.
Yeah, I am one of those people, because I slept right through the alarm. Excuse me. I was so stressed and panicked the night before because I knew I had this alarm going off, and I slept through it, and woke up in an absolute panic. I think I've missed it by a few hours. My clinic were furious with me.
Well.
But it was my final round of ICSI that happened, and fortunately everything still worked out okay, so I can't have left it too late. But so with IVF, then, that is the eggs and sperm in a dish, and hopefully that sperm will penetrate the egg. So for me, none of the sperm didn't penetrate the eggs, so I didn't get one single embryo, which was devastating. So then we move on to ICSI. So can you explain ICSI?
Sure. And when, again, IVF was first invented in the late 1970s, the aim was to put the sperm and egg together in a dish and wait for sperm get into an egg. That was the first attempt, first aim. And then throughout the years, male factor cases started increasing in the clinics. And if the sperm sample, count is very low, sperm didn't get into egg in the dish and failed to fertilize the egg. Then scientists started trying another option to get the eggs fertilized. And ICSI was invented in 1993, 1994. Sperm, during ICSI procedure, sperm is injected inside the egg. Then it dropped fertilization failure in couples with male infertility. It helped a lot. It helped couples get fertilized eggs and healthy children. So ICSI is different from IVF by means of injecting sperm inside the eggs. There is a debate in the recent years if the ICSI is mainly an indication in male factor infertility. If sperm count is low, ICSI is a gold standard. But the question is, should we do ICSI in all couples to prevent fertilization failure? This is a hot topic among infertility in IVF specialists. Should we do that? I know many countries, Turkey as well, choose to do ICSI procedure in all couples. Male factor, unexplained infertility, or tubal factor, whatever it is. But in some countries, as in UK, I believe, they still keep doing IVF, conventional IVF. So ICSI is not superior to IVF in cases with normal sperm count. I like to emphasize that. I'm not saying that ICSI should be done on all couples in all infertility causes. But in Turkey, since we are afraid of total fertilization failure, ICSI is performed in all couples, but there are still debates over this issue.
Oh my gosh. Okay. And how long does a round of ICSI take? So how, because again, going back to the time is such a precious thing for anyone trying to conceive. Everyone wants to just know how long until I'm going to be pregnant. How long does that cycle take?
It's similar to IUI. The ovulation induction phase of the treatment lasts approximately, again, 10 to 12 days. After 12 days, we give the trigger. 2 days later, we do the egg collection. And usually 5 days later, we do embryo transfer. So in total, it takes 17 to 18 days from the beginning of cycle till the embryo transfer. After the embryo transfer, 10 to 12 days after the embryo transfer, we call for a pregnancy test, which can be done in your country, in the country where the patient lives. So couples should stay in the country of IVF unit for approximately 18 to 12 days, considering some delays, but these are the approximate numbers.
And just finally, I think something I wish I'd been told before I started my journey was just the kind of the fact that it's nothing is guaranteed, because I think I just thought that IVF was guaranteed. I didn't really understand it, which is why talking to you today is so brilliant. So if you're going for, like, basically, I think what I'm asking is, how many rounds really are you looking at? Is it possible to say until you might have a successful outcome? Is there an average?
It's not possible to say how many rounds you need to get to get a baby. But again, the age is very important in the pregnancy rate, to predict pregnancy rate. I usually recommend 4 cycles, 4 attempts to get a baby. After 4 attempts, the pregnancy rate significantly drops. So it needs to be understood that you should go at least 4 cycles with a high pregnancy rate. Don't be discouraged to try IVF for the first IVF cycles. Then you should consider, some other methods, some other donor cycle or whatever. So the age of a woman matters in the prediction of IVF cycle. If you are 35 and younger, almost 40%, the clinical pregnancy rate, 40-45%, and take-home baby rate is about 40% under age of 35. 35 to 40, I'm talking about one pregnancy rate per cycle, not cumulative pregnancy rate. After age of 35, it drops to 35%. At the age of 40, it's about 25 to 30%, and over 42, it drops to 5 to 15%. So this would be my advice to women, that please do not delay your child programs, because delaying your having a child, should have some negative impact on your ovarian reserve. Please do not delay too much. Go to a doctor and have a child. Brilliant
advice. Again, I always say I wish I'd had these chats years ago. I think my journey would have been a lot shorter and a lot quicker had I
Thank you very much.
made these, had these conversations and made these decisions a lot earlier, and actually understood my treatment, because I went in blind. I didn't really understand what the process was. I didn't really understand, like I said, what the sort of percentages were, or the facts and the figures. So I'm really hoping that people today will take your guidance and just act, get the right tests, and
right.
Yeah, get cracking. I'm going to stop there because I know you have to get back to clinic, but thank you so much for your time. And I
You're
really
welcome.
hope we can pick another topic another day and I can steal you away.
I'm very happy to meet you. I hope to see you again in the near future.
Thank you so much.
Bye-bye.